Vicky hosted with Dr. Panchal because I'd bunked off on holiday. So I believe you asked for Sonia to come back and do a lecture on giant cell arteritis. So she is here to do that for you. I will send out afterwards a PDF of the presentation so that you don't necessarily need to take too many notes. And at the end, we'll also ask you to fill in a feedback form for us, which I'll also send out to you again by email as well after the meeting. And for those of you who've just hopped on the call that didn't hear it beforehand, Dr. Panchal is going to present without her camera on because she hasn't been very well, but she still wanted to talk to you today. So are you ready to go, Sonia?
Yes, ready.
Okay, then I shall hand over to you. Vicky is going to move the slides on. And if you have any questions, please either put your hand up, pop yourself on camera to ask the question, or type into the chat and I will ask the question on your behalf. So any way you want to ask questions, please do. And are you happy, Sonia, to be stopped throughout the presentation with
questions? I was
questions?
going to say that anyway, yeah.
Okay, right.
Perfect.
I shall mute myself and turn my camera off, and it's over to you.
Thank you, Mel. Thank you, Vicky. Thank you for everyone for inviting me back. It's always really lovely to be called back to do another presentation. Forgive me for not being on camera. It's not just because I'm unwell and actually currently off work. My face is also like a football because I've got a bit of an allergic reaction. So even if I was slightly well, I'd put my camera on, but I don't think you'd want to see my face as it is. So thank you for honouring that for me. So today's presentation is all about giant cell arteritis because that was the topic that came up last time, and this is a topic that, if one for a better word, can often frustrate me from secondary care and no doubt will probably frustrate you from primary care. But the onus of today really is to give you the perspective from primary care and a little bit about secondary care, and it will all make sense as I go through the presentation. As Mel has said, I'm more than happy to be stopped. Please feel free to ask a question. You can unmute, you can put it in the chat and Mel can tell me. I can stop in between, and also if you want to put your camera on, feel free, just because it's just nice to kind of get a feel of the energy of the room. I appreciate mine's not on, but even so, please feel free to do whatever suits you. So for those that were here last time, you probably already know a little bit. Oh, next slide, Vicky. A little bit about me. So I'm obviously a rheumatologist. I work in Warwick. I started working there just before the pandemic. I've been a consultant for over 5 years now. I used to work at the Royal College of Physicians as Deputy Registrar. I finished that role earlier this year. And then I've obviously got different interests as well outside of work. Next slide, Vicky. So the purpose of today's talk really is I contemplated what would work best. I'm very much a kind of hands-on case type person rather than just didactically teaching from a textbook style, like do this, do this. And I thought what would be really helpful, given that you're based in primary care, is give you the perspective from primary care. So as if the patient comes to you straight through the door and you're dealing with someone with a potential case of giant cell arteritis, and talk you through that. Then I'm going to talk a little bit about the process of what to do when you think you've got someone with giant cell arteritis. And then I'm going to interweave some teaching through that, through using the case as an example. And then I'm going to give you the perspective from me, from a rheumatologist, as to what happens thereafter. Because although I want you to focus on the primary care, it's always worth knowing what happens in the secondary care strand as well, for your own reference. I do have other cases. I haven't prepared them, but I'm more than happy to talk through other cases towards the end if we have time. But the main focus and purpose for today that I would like you to take, or invite you to take away, is how to approach a patient with this and what to do when you are convinced or suspecting it from a primary care perspective. So next slide, please, Vicky. Now, this might appear a bit dramatic, but essentially, giant cell arteritis, or GCA as I may refer to it intertwined between the two, is a medical emergency. And often you think of a medical emergency as like, oh, blue light straight to A&E. Not necessarily. This will come apparent if you don't know why it's a medical emergency later in the talk. But this is something that needs rapid attention, cannot be left, needs to be seen, and essentially sorted out with a pathway or some kind of instruction and treatment. And so I'm trusting that by the end of this presentation, firstly, you'll appreciate why it's a medical emergency, even though the connotations or the definitions of emergency can differ. But from a patient's perspective, it is an emergency because of the complications that can arise and how to mitigate that. And a lot of that is around time. Next slide, please. So I'm going to talk through a patient A, that comes to you in primary care. And we're going to kind of build on the case as we go through, whilst I'll give you some teaching in between. Next slide, please, Vicky. So you turn up to work, you're in your office, in your surgery, in your room, and you get your list and you see that someone's coming in with a headache. And so this gentleman comes in. He's a 65-year-old male, and as per usual, you say, "How can I help you today?" And you give them their, well, I think in the textbooks it's at least 2 minutes, but often we don't have 2 minutes for them to go on. So you give them 30 seconds to say what the problem is. And they sit down and they say, "Doctor, I've got a right-sided headache. It's been there for a few days. It's getting worse. I've tried paracetamol, I've tried ibuprofen, I've tried all the, over the counter, but it's getting worse and it's really bothering me. So I thought I'd come and see you." So rather than me ask you what you would ask next, because you're all going to be brilliant at telling me what to ask in a history, are there any specific questions that come to mind that you may ask based on that, given the fact that we are a GCA presentation? If you do, just pop them in the chat. And Mel, if you want to shout them out, if people do post. I can't see the chat, you see, so feel free.
I'll let you know.
Yeah, let me know. I'm going to continue anyway.
Hang on, before you continue, we have an early one here. Scalp tenderness.
Yes. Anything else?
Visual disturbance.
Yes.
Jaw claudication.
Very good.
NV.
NV. That's a new one on me. Please outline your abbreviation, please. I don't know what NV is. Should I?
Nausea and vomiting.
Oh, nausea. Oh, you need the and in between.
Sorry. It had a dash in between. That's probably my fault.
If I'd seen, I'd probably known. It's okay, Mel.
Don't forget, guys, I'm not clinical.
Okay, next slide, please, Vicky. So yes, you've got all the right questions with respect to giant cell arteritis, and I'm not surprised because everybody knows the symptoms. So just to talk you through that, I think one of the things to bear in mind is people's age. Now, we know that age is not the exact, so you must be 50 or, one day over to have it. If you're less than, then you don't. That's not true, and we all know that. But this is a condition that usually affects people of more mature age. The textbooks say 50. I would say in experience, it's more like late 60s, 70s, 80s. The majority of people, and they tend to be more female than they are male. So age is quite important, because if you tell me you've got someone who's 20, I'm probably going to be scratching my head going, is there something else going on? So they usually present with a new onset headache. So it's not like they're normal headaches that come and go. It tends to be a new headache, often in the temporal region, but not always. And it's a relatively rapid onset as well. But it can also present in the frontal region, the parietal region, or the occipital region as well. So just because it's not in the temporal region does not mean it's not GCA. And there is there can be characteristics of giant cell arteritis, and they do not have a headache. So this is where the skill and the art of medicine comes into play. And so it's great that everybody knows all the symptoms of GCA, but often patients don't present like a textbook. They present with weird and wonderful presentations, and it's still GCA. So hence the question I asked, what symptoms you would ask for, but then don't be alluded to the fact that they haven't got it just because they answer negative to all those questions. So just be really mindful of that. Like I said to you, it does tend to be rapid or an abrupt onset. So that should be already giving you alarm bells as to what's going on here. That's quite quick. Something's not right here. Yes, scalp tenderness, everybody knows that one. Brushing, combing your hair is a great question to ask. Occurs in about 30 to 50% of patients, and they usually just go, oh, it's a bit tender when I press or when I comb. It's usually the way that they describe it. But as you know, giant cell arteritis is basically inflammation of the arteries, which then occludes the lumen, meaning blood flow can't go. So there are episodes where you can get necrosis of the skin that you would see, and so you can get scalp necrosis. It's very rare, but it can happen. So you just need to be mindful of it. If someone comes in that hasn't really bothered to come and present to you earlier, they could be showing complications or late features of GCA. I've never seen it in real life, to be honest. Most people have usually sought medical attention by then, but it can happen. The temporal artery obviously is a good giveaway. That patients often describe this as being thickened or kind of prominent when they look in the mirror, like what my vein is sticking. They usually describe it as a vein. My vein is sticking out. Obviously, it's the artery. It can be quite tender over there or feel quite thickened and hard. And again, that's a consequence of the inflammation that you get. When you're examining them, obviously you want to feel for the temporal artery pulse, which if you put, and everybody's arteries are slightly different anatomically, so don't always assume, a bit like normal pulses anyway, you know, just have a good feel around and see if you can feel it. Press gently, not too hard, because you can diminish it. But obviously if it's very inflamed, it can have a decreased pulse or an absent pulse as well. And sometimes the area can look red as well, so just be watchful of that. Jaw claudication, as you said, very highly specific for giant cell arteritis. Just be really clear in distinguishing what the patient means or the question that you ask. So it's not just do you get jaw pain, because that could be a lot of things. For example, it could be TMJ dysfunction. It could be trismus, which is basically locking of the jaw that can give rise to pain. You really want to ask, do they get pain as they start chewing or talking? Because that's claudication. Think of peripheral vascular disease in the legs. You get more and more pain as you walk. It's the same thing with the jaw. So you want to make sure that you're very, very clear in the descriptors that the patient gives you to delineate whether it is jaw claudication or some other form of jaw pain. Visual loss we're going to cover a bit later, but yes, absolutely, you want to be asking questions about that. And then the constitutional symptoms, so weight loss, fever, night sweats, fatigue, again, indicating that there may be some further distal involvement or systemic involvement as well. Just to go back to the jaw claudication, I forgot to mention that it can often, the claudication can also affect the tongue and the swallowing muscles as well. So just be mindful of asking questions about that as well. Very rare, but something to be mindful of. Next slide, please. So this is just a graphical representation. So you can see on this gentleman on the left-hand side that you've got a thickened temporal artery. And you may recall that I commented that the headache doesn't have to always be temporal. And the reason for that is if you look at the vasculature around the area, gives you the explanation why. So you can see, oh, I can't, you're not going to see my pointer, are you? Okay, it doesn't matter. So you can see you've got the external carotid and the well, you can't see the internal. So you've got the internal at the back that's going further shaded. Don't worry about that. So let's go for the external carotid, which then branches up past the ear into the superficial temporal artery, which then has branches which come over to the frontal side. So that's the frontal superficial temporal artery branch. And then you've got the branch that kind of veers off towards the upper aspect of the ear, but further up into the parietal region. That's the parietal superficial temporal artery, the branch of that. So that's why you can get temporal pain, you can get frontal pain, you get parietal pain, because it's all shooting off from the temporal artery. But you can also see from the external, if you've got more distal involvement, which you can have, that you can also reduce the supply to your occipital artery, and therefore you can get an occipital headache. If you come further down, so off there, you've got the linguinal and the facial artery. That's what can give rise to the tongue and the jaw claudication. And you can't really appreciate it, but then from the internal carotid, you then get the ophthalmic artery, and that's the reasons why you get visual involvement as well. And I'm going to talk about that a bit later. Next slide, please. And here's a demonstration of scalp necrosis. So this is obviously of the temporal region there. There were some even worse pictures, which I didn't really want to share given it's lunchtime. But essentially, yeah, if you've got something like this showcasing around the temporal region or the scalp, then clearly you want to be inquiring about GCA. Okay, so next slide. The other thing to be mindful when you're taking your history, obviously, if you had this gentleman present with the headache, not only will you ask the GCA questions, you would also ask about any type of questions that you would do ordinarily for headaches, because there's lots of differentials and mimics of GCA. And so for the purpose of this talk, I didn't ask you to give me all those questions. But the things to be mindful of, and this is really important because often we get a lot of referrals. And if you take a really good, clear history, you figure out that actually it's not GCA, it's one of these or maybe something else. And there's a couple of funny stories, which I might share one of them when we get to the mimics. But cluster headache obviously is usually more unilateral, so obviously that can be deemed to be possibly giant cell arteritis. Cervical spondylosis often originates in obviously the cervical spine, which radiates up into the occiput and can come round to the frontal region. And so often the cervical spondylosis can actually be the cause of their headaches, and it's nothing to do with GCA, and investigations and clear history taking and examination can allude to that. People who've had sinus infections or sinusitis can get similar symptoms, ear conditions, connective tissue disease. Like I said, temporomandibular joint pain, be really, really clear in what they mean by their joint pains. And also, although giant cell arteritis is a form of vasculitis, meaning inflammation of the blood vessels, there are other vasculitides that can present similarly, and you don't want to miss them because the treatment might be slightly different. Their outcomes will be different, their prognosis will be different. So you've just got to be mindful that, am I actually dealing with a giant cell arteritis, or am I dealing with some other form of vasculitides? The mimics, the herpes zoster always reminds me of a funny story. When I was a registrar, I had a GP call me and I was running a hot clinic, which is basically, you know, urgent cases coming straight through to us direct. And they said, I can't remember how old she was. I think she was just over 50. I can't remember exactly. It was many years ago. And they said, oh, we're convinced she's got this. And we've sent the blood test. They're not back yet, but please, can you see? And I was like, okay, well, I have got a slot, and otherwise it's going to take another few days to get her in. So I saw her and took a history. And there was something about it that I can't remember exactly, but I wasn't particularly convinced. And she basically, before I examined her, and being completely respectful to her, she had a very blocked fringe. If you think Claudia Winkleman, she had one of those fringes that was literally on her eyes, very thick, very blocky. So you couldn't really see her frontal head at all. So I went to examine her, and I'm very nosy, you know, you're digging right in there in the scalp, in the hair. And I lifted up her fringe, and basically she just had shingles. And she goes, that's where it's really painful. And I was like, did you not notice this? She goes, oh, I didn't realize it was quite subtle, to be fair. It wasn't the most prominent. And I said, did your GP lift your fringe up? Said no. This was before the days of COVID and telephone consultations. But even so, I was like, oh, well, this is the culprit. It was herpes zoster. So don't be caught out by that. Just really examine your patients. Migraines, basal skull, TIAs, obviously, and then any other forms of lesions in the orbit that could account for visual loss. So next slide, please. So how are we doing for time? I have a tendency to talk a lot. So right, so you've got a bit more history now from this patient. You've established that it's a rapid onset right temporal headache. It's come on over 48 hours. It's getting worse. There is pain over the temporal artery. There is scalp tenderness. There's a bit of pain on talking, and they've now got some. They're admitting to blurry vision. Painkillers haven't really helped. So next slide, please. Visual symptoms. So in the chat, if you can, what would you be asking about visual symptoms? What are you worried about? Anything coming through, Mel? Otherwise I'll move on.
Not yet.
Not yet. So
Hang on, somebody's typing.
Okay. Give them a second. We're due to finish at 1:30, aren't we? Okay.
Yes.
It'll be all right. I can rattle through the second.
Visual loss.
Yeah, what does that mean? How would you ask?
Blurriness.
Okay,
Curtain.
Pardon?
Curtain.
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 Oh, curtains. yes, I get what they're.
Photophobia.
Yeah. Okay, let's move on, and then we can establish what the visual symptoms relate to. So essentially, giant cell arteritis can affect the visual aspects because of the nature of where the blood supply comes from and the arteries that get affected. And again, I've got a diagram a bit later to kind of showcase this. About 50% of people present to ophthalmology because they've got visual problems and they don't realize what's going on, and then it turns out to be GCA. About 20-30% come to us, possibly with eye problems, and then we end up redirecting them. And basically, they can get visual loss. And the reason for that is there's different types of ocular inflammation that they can present with. And this is where it comes down to being a medical emergency, and I'll explain why. So the most common problem that they get is anterior ischemic optic neuritis. It's basically they get an interruption or an occlusion or inflammation in the posterior ciliary arteries, and they present with this kind of sudden, painless visual loss. But they don't often rock up by the time their vision is completely gone. They're coming because they've got a bit of blurry vision, or their visual fields feel a bit misty. And so that is a really good indicator that something might be going on. It can also be just in one eye. So often a lot of people disregard it. Actually, they just go, I had a bit of a float or a bit of blurring, but it disappeared, and and I just ignored it. But now it's staying, and so that causes them to be a bit alert to it. But it can also go in one eye and then start to affect the other eye as well within about a week or two. So it's really something you've got to be really tuned into. And the reason being is if it's left alone, it can progress to irreversible blindness as rapidly as 24 to 48 hours. That's how quick it can happen. It doesn't always, but can happen. And that's the part of the medical emergency for GCA, is that if they have any visual disturbance, you need to go there and treat them straight away, irrespective of what the diagnosis is, because you want to prevent that irreversible damage. It's better to give them treatment and then take it back than to not give it and they go blind, because we can't reverse that. We can always take drugs back out, they'll have it for a day or two, whatever, but at least you can stop the drug. Whereas with blindness, you can't. So that's the real importance of it. The central retinal artery occlusion speaks for itself. You get an occlusion of the retinal artery. Amaurosis fugax is the curtains coming in. So that can also be for other indicators like TIA. So again, if you've got symptoms like that, you want to be thinking, is it really GCA or is there something else going on? But it is a good predictor of visual loss. So again, that's another kind of, red flag alert, need to do something about this, can't just wait and sit on it. That occurs in about 2 to 30% of patients with GCA. And then you get diplopia, which is true double vision. And that's to do with the oculomotor nerve, where that becomes ischemic and therefore they get the double vision. That's much more rare. That's more like 5 to 6% of patients. So next slide, please, Vicky. So this is just a diagram to illustrate that. So I don't have my pointer, I can't show you the pointer, but if you follow up, this is now the internal carotid artery that we're looking at further down, right near the bottom. And then you follow that up and you've got the ophthalmic artery, and off that you get the posterior ciliary arteries. And it's those arteries that get occluded that give you the most common complication, which is obviously the anterior ischemic optic neuritis. If you go back down to the ophthalmic artery, it then branches off into the central retinal artery, which is where you get the occlusion there. So you get those symptoms then. Obviously, you've got the ophthalmic artery that follows through up top as well. So that just gives you a kind of diagrammatic representation, and that's all off the internal. And then obviously you've got the external carotid, which then gives you all the headaches and the parietal, temporal, frontal aspects. Next slide, please. So this is just a quick I'm no ophthalmologist. I did ophthalmology as an F2, so I can use a slit lamp, but I haven't done so for many years. But essentially the diagram on the left shows a normal optic disc, nice and clean, well demarcated edges, but you can see on the right hand side that it all looks a bit fluffy, and that you've lost the demarcation because of the ischemia. Next slide. And this is an example of a central retinal occlusion, which, when you're doing your fundoscopy, hopefully you'd pick up, but if not, not a problem, because you'd send them to ophthalmology anyway. So next slide, please. So now you've got a bit more information. So you now know that he's got diplopia as well. So next slide, please. Now what are you going to do? So in the chat, if you can tell me, what would you do? You're obviously sitting in front of this gentleman. You've done everything in terms of ask those questions. You've delineated that they've got scalp tenderness, pain on talking, and diplopia. Nothing's working in terms of analgesia. What are you going to do now? Any comments before we move on? Anything, Mel?
Nothing as yet. Oh, hang on.
Oh, is everyone stuck? Or
high dose pred -refer.
What's high dose and who you're referring to? It would be my question. Okay, let's move on. You can contemplate that. Okay, next slide. So I would not refer just yet. I would be still asking my questions. And the reason for that is you want to make sure there's no other clinical features or complications. So Now, I appreciate in primary care you don't have much time, but these are quite quick that you'll distinguish quite quickly through your history, but I'm just making a point of them so that you don't forget them. So you want to make sure there's no other large vessel involvement, because effectively giant cell arteritis is a large vessel vasculitis. So any large vessel can be affected. And as I alluded to earlier in the talk, you can get distal ischemia, which is why you can get some other symptoms such as occipital headaches, because the occlusion and the inflammation is further down in the vasculature. And one thing to be really, really mindful of is the aorta. So you can get risk of aortic rupture and dilatation if you've got involvement of that. So you do want to make sure you do your kind of systems review, ask about chest pain, shortness of breath. You want to know if there's anything there that could account for more involvement of the vasculature other than just up in the temporal region. And so you would do that through your questioning and also through your examination. So you're listening for bruits, making sure their peripheral pulses are all okay. Obviously, you want to make sure you're not missing a stroke or any other form of kind of neuropathy, and the respiratory symptoms may give you rise to infections or other forms of large vessel vasculitis. So you don't want to forget those. Another thing that can present as GCA is pyrexia of unknown origin. So if someone's very feverish and you can't find anything and they've got raised inflammatory markers, it could be a vasculitity, it could be giant cell arteritis. But I'd like to think that if you got to that stage, they'll probably be admitted and managed in secondary care and investigated further. So next slide, please, Vicky. So there's no other clinical features. Next slide, please. And so you're going to examine them. Next slide, please. So the things to watch out for, particularly in this, is obviously make sure their heart rate, pulse, and their observations are all okay for reasons that we've already alluded to. Check their peripheral pulses as well to ensure there's no other vasculature that may or may not be affected. Obviously, feel around the temporal artery, see if they've got scalp tenderness, assess their jaw, do a full kind of examination, make sure you do a neurological examination as well. And if you can, try and assess their visual fields and do a fundoscopy. But if you're running out of time and you're quite convinced there's something going on, I don't think it would be unreasonable just to refer over to ophthalmology. Next slide, please. So now what are you going to do? So that's where I would be like, where are you going to go? So someone said start steroids and refer. Is there anything else you'd do? Next slide, please. This I'm really interested in to hear people's thoughts. This is the bit where it often falls down from a secondary care perspective.
I've got one comment here that says bloods.
Yeah.
ESR.
Just ESR?
I have someone else typing as well.
I'm really keen to hear the thoughts on this, because I'd like to kind of give you a strategy for this, because this is the conversation that I spend more time on when dealing with cases of GCA than anything else.
Right, I've got fundoscopy.
Yep. So you did that in your examination. Yep.
CRP.
Yep. Would anyone else do anything else?
Got someone else typing.
Great. Oh, we're good for time, actually. I thought we were.
It's 1 o'clock. It's just coming up to 1 o'clock.
That's okay. Good, then we can have a bit of discussion.
Okay, nothing's coming up on the chat.
Okay, let me go to the next slide then.
Okay.
So you want to do some investigations for sure, because you want to try and get to the bottom of what's causing it. But equally, you also may want to give some treatment as well. So I appreciate that. So ideally, you want to know if there's inflammation, because majority of cases do have a rise in their inflammatory markers, which is a great indicator for you. But don't be alluded to the fact that inflammation can occur for anything as well. So you want to make sure it marries up with your history, your clinical findings, as you would do in any kind of medical setting. The other thing to say is that you can get GCA with normal inflammatory markers. There are some case reports. It's very rare, very rare. But equally, don't forget that people who might have other inflammatory conditions might always have a rise in their ESR, CRPs and PVs. And so again, this comes back down to being an art, that you have to kind of then figure out whether you feel that the rise is because of what they've already got, or is it because there's something else? Has it gone higher on what their normal ranges are? So that will, again, you can't just base it on standalone blood tests. The guidance is we check CRP and then we check either or the ESR or PV. Primarily depends on your labs. When I was a registrar, we used to use PVs a lot. I think in Warwick we used PVs for a while. I've just recently switched to ESR. But either way, ESR or PV, you don't necessarily need both. I would do one or the other, and your lab will probably dictate which one you're going to do. You'd obviously do an FBC. Often you can see anemia of chronic disease. Given that it's inflammation, it's no surprise that your platelets may be up, your fibrinogen, haptoglobin, which I don't routinely assess, actually. That's not my routine blood test for GCA. And you can get a rise in ALP. The anticardiolipins I wouldn't expect you to do. They're just there as a kind of, in case you're worried about some kind of venous thromboembolic disease or clotting disease, then you may do anticardiolipins, but I wouldn't expect you to do them. If you are worried, probably speak to a specialist before ordering them, because one thing I particularly do not appreciate is tests that are done and then there's no clinical interpretation because nobody understood why they were doing it in the first place. But yes, the most important blood tests for this, and the question I will ask you is, what is the ESR, CRP, or PV? Next slide, please. This is probably the most important slide. If you can go away with one slide, this will be it. Because this really helps us in secondary care, and I'll tell you why later, but it's really, really crucial. This is the most crucial thing, is when you've got this patient in front of you and you're suspecting it, the first thing I want you to do is give them a blood test form and tell them to go and get their bloods done. Now, I appreciate that sometimes it can be difficult, but majority of the time you can get a blood test on the same day. I don't know whether that's through your practices or whether you present to hospital, but it's really important that they go and get that blood test first, because I want to know what the inflammatory markers are before you give them an ounce of steroid, because even within 24 hours, those inflammatory markers can go right down. And when I then come to see the patient, I don't know where I am because I don't know what the inflammatory markers were. And this has real impact into what potential investigations and subsequent treatment I'm going to give them, which can be up to 2 years. So this is why this is really important information. So what I advise is you give them the blood test form and you advise them to go and have the blood test, but you at the same time, you give them a prescription for the prednisolone. And you say to them very, very clearly, I want you to start this treatment the minute you walk out of the phlebotomy room. You know, as soon as you've had your bloods taken, then you're free. Go and start your steroids, get them in and get started. Do not wait for the results, because if you're suspecting it in the first place, what are you waiting for confirmation? We treat before we get confirmation for the reasons of the medical emergency that I said before, because you have short windows before things start getting very complicated, particularly if they've got visual issues. So if anyone's got any comments on that, and I'd like to know particularly if there's issues with doing that from a primary care perspective, because from the people that I've spoken to, most of the time they've managed to get it. The only time they haven't is because the patient wasn't informed appropriately that they needed to have the blood test before they start the steroid. So please feel free to share your experiences around that. But in an ideal setting, that is what should happen. But fully appreciate that often it can't. If you really can't get the blood test and it's going to be days before you get them, obviously you want to get them on treatment because that's more important. But if you do have a window where you can get them to have their bloods, please get their bloods first and then ask them to start the treatment. So please feel free to share any comments if they come up, Mel, around that. So next slide.
I've got one that has just come up. Authorization from GP for high dose steroids advising to send in instead can be an issue sometimes.
Oh, I don't understand. Say that again, Mel.
Authorization from GP for high dose steroids advising to send in instead can be an issue sometimes.
I don't know if that person could just unmute and just clarify the question. Do you mean that you need authorization from someone to give them high steroids or to refer them, or I'm not quite clear?
Yes, authorization for issuing high dose steroids.
Yeah, that's fine. I mean, I appreciate that as PAs, you may need to get that authorization, but as long as you present the case appropriately to your GP, then getting authorization for steroids, I think, is appropriate. That's fine. There should be no delay in getting that authorization from a GP. And if that is the case, then that needs to be dealt with in your practices, because that's not appropriate. There should be no delay, because this is a medical emergency. So
said Sonia, sorry, the GP would prefer to send the patient into A&E due to risk.
Okay, right. So I disagree with that. So let's talk about that at the end, because let me go through this presentation, and then it might be something that, yeah, A&E is not the appropriate place either. Let's go through the presentation, and then you can tell me and share any of those experiences, because I categorically disagree with that approach, and I'll explain why in a minute. So that's very interesting. Thank you for sharing that. Okay, next slide. Okay, so treatment. This is where it gets really, it's not complicated, but it can get complicated. And I don't like this term uncomplicated, but it's the terminology in the guidelines. So uncomplicated GCA is deemed as no visual symptoms and no jaw claudication. And when I'm talking about treatment, I'm talking from your perspective in primary care. So if they've got uncomplicated GCA, no visual symptoms, no jaw claudication, you want to start them on high dose, meaning 40 milligrams of oral prednisolone. Now, the guidance says 40 to 60, and I guess it depends on whether you think there might be a bit of blurry vision or jaw claudication, or if they've got any systemic involvement, feeling very generally unwell, you may want to bump it up to 60, sorry. But essentially, you start them on 40, you give them a month's supply, and then you want to refer them to rheumatology urgently. Okay. When they've got complications, and complications are defined as visual disturbance or symptoms, jaw claudication, or just generally systemically unwell, then clearly you want to start them in primary care on 60 milligrams once daily, give them a month's supply. And because they've got visual symptoms, you want to refer them direct to eye casualty or ophthalmology. Now, when I say refer, this is where it all gets a little bit broken as well, because it depends on your local pathways. So in an ideal setting, you'll have a pathway with your local hospital, and it will be, depending on the pathway, it'll be straight to ophthalmology or straight to rheumatology. For some hospitals, it might be actually you don't go to ophthalmology, you go to the medical care units, whatever, the AMUs, or you go to eye casualty. So it depends. So you need to be familiarize yourself with what the local policy is. For us in Warwick, it's still a little bit haphazard. My understanding is they can either present to AMU, present to the GP and go straight to AMU. The GP can refer them into AMU, and then the AMU will assess them. And then they come to rheumatology. Now, I grew up in an era where I was training that the GP would ring us directly. I would be the reg on call. I'd have a bleep. The GP would ring me, actually ring me, not just do a referral. Do not do a referral letter without speaking to someone, is my opinion. Speak to me. I'd go, yes, absolutely, happy to see them. I'll book them in. Give me the details, and we get them booked in, and then a referral letter would follow, because the referral is more for the system. I just want to know what they've actually got. I would love to speak to the GP direct, get the symptoms, and go, actually, it's this. Yes, I do want to see them. No, I think you need to go to ophthalmology. Or no, have you thought about this? Have you thought about that? Whatever the situation. Now, that doesn't always work because people have different pathways and different opinions. But for me, GCA is something that needs to be seen ASAP. And when I was a registrar, we used to see them same day, next day, or at least within 48 hours, because of the nature of what the investigations you need to do thereafter, and time is of the essence. So although we say refer, you need to determine what is the referral pathway for your practice and your local secondary care hospital. So next slide, please. When you're giving the steroids, please give bone protection if they're not already on it. Calcium, vitamin D supplements would be great. You may want to consider a bisphosphonate, but at that phase, you're probably too early because we still haven't determined the diagnosis. But later on, if they've not been put on a bisphosphonate, that might need consideration. Obviously, in rheumatology, we would consider that anyway. But if it's not picked up, or if you come across it and you think, oh, hold on a minute, they have got GCA, they're going to be on treatment for some time, we need to think about bisphosphonate. Obviously, with any kind of steroid, you want to advise that they take it on a full stomach and have gastric protection. The guidance also recommends baby aspirin, but we don't tend to give it pre-diagnosis, purely because if they do need a temporal artery biopsy, we don't really want them on aspirin as far as we can. And obviously, make sure there's no contraindications. If they're already on aspirin, it's fine, just carry on, not a problem, but you wouldn't necessarily by choice give them aspirin. So, any questions around treatment?
There's nothing currently in the chat.
Okay, great. I didn't say, sorry, I probably skimmed past it because I got very passionate about this, is that in ophthalmology side, yes, you start them on 60, but they may progress onto IV methylprednisolone if they've got significant ocular features of GCA to protect their vision. We do end up having to sometimes admit them to give them IV methylpred. It's often done through ophthalmology. It's rare that we have to do it, but nevertheless, if there is something evolving, and the chance of risk of blindness, then sometimes we have to go even escalate the treatment with IV as well. So, okay, next slide, please. So when you're referring, next slide, please, referral to secondary care. So this is from my perspective as a rheumatologist. If you're referring to me, there are some important indicators and information that I would like you to tell me when you're referring. One, it speeds up the process and becomes more efficient. It also gives me the important information I need to decide if I need to see the patient, if I can refer them somewhere else, if they need something other, anything else going on. You know, these are the kind of bits that I would like to know from you. And this is probably another important slide to be aware of. So obviously you know, it'll be obvious that you're going to tell me the male, female, and their age, because again, if you're referring me a 20-year-old with a bit of a headache, I'm going to probably be less interested than someone who's 75 and got a unilateral headache with jaw claudication. Obviously, tell me about their symptoms, and even if they're negative, it's quite worth knowing. So if they haven't got scalp tenderness, if they haven't got jaw claudication, again, partly because I'll understand what you mean, and then the treatment might change. And if you're given 60, I might say reduce to 40 of steroids. So again, these are really important bits. So scalp tenderness, visual symptoms, jaw claudication, constitutional symptoms, if you've got any cardiovascular involvement as well. As I've said before, the timing of the bloods to commencement of treatment. If you've already got the blood results, I want to know, were they taken before the steroids, and what were the results? And if they weren't, tell me that. And if you haven't got the results, that's fine, you know, as long as they've been taken. And if they haven't been taken, then even more reason to tell me that. Obviously the dose you started at, did you start 40, did you start 60, what did you do? If you know if they've had any response, that's helpful. And the way I assess response to treatment is usually in a percentage. So I'll say to the patient, you know, in terms of your pain, how much has it improved in a percentage? So has it improved by 10%, 50%, 80%? And often people within 24, 48 hours feel a lot better, at least above 50% improvement in their symptoms. Not always, it can take up to a week, but majority of people do notice quite a significant improvement, even if it's slightly lesser on the scale. And the reason I've put mobility there is because if I'm on the phone and I need to get them in quickly, how quickly can they get here from a mobility perspective? If I need to get them over to a different hospital for an ultrasound or a temporal artery biopsy, are they going to be feasible enough to have these investigations? Because like I said, time is of the essence, and if their mobility is impaired, then that might change the way I manage the patient overall. So this is the kind of thing, if you're writing a letter after you've spoken to someone or referred them in or referred them to AMU, this is the kind of information that we need to see in the referral letter. If you give me this, always in my good books, because then I can just go, right, this is what we need to do. Obviously, I will do my own assessment and take my own history and all the rest of it. But this information can really help for us to kind of triage and determine how quickly we need to see these patients. So where are we for time? Any questions on that? We've got 15 minutes left, so I'm going to rattle through the next few bits. But is there any questions about that? Because that's kind of at the point of where primary care kind of alleviates all their responsibility to us. So any questions about that? Because I'm keen that we're in a primary care setting here.
There isn't anything in the chat at the moment.
Great. Okay, so let's go to the next slide. So I'm going to, like I say, I'm not going to dwell on the next section too much, but feel free to ask any questions if you want me to deep dive on any of these. So next slide, please. So yes, what am I going to do when I see them? I'm going to obviously see what their response to treatment is. I'm going to review for any systemic involvement. I'm going to decide if they need any investigations, adjust the treatment accordingly, and then decide whether I need to monitor them through regular follow-up or discharge because I've excluded GCA, and I'm always reviewing for potential complications. So that's my purpose in the kind of pathway of seeing these patients. Next slide, please. So this just is a breakdown of what GCA is. I'm going to just rattle through this. Essentially, all I want you to focus on here is just the bottom picture with the lumen that's significantly narrowed because of all the inflammation of the mural wall, so the arterial wall, and that's what happens. You know, you can see the normal one next to it, and you can see the inflammation in that one. So, and this will become apparent in the investigation. So next slide, please. So next slide, please. So when I see the patient, I'm deciding on whether to do a temporal artery biopsy. So this is a non-invasive, very quick procedure, like any ultrasound. It uses color Doppler. So first to assess the blood flow and see if there's any kind of stenoses, occlusions. And what we tend to see on an ultrasound is a halo sign. I'm going to show you a picture of what that looks like. And the halo sign, which you'll appreciate, is basically the inflamed wall that we're seeing. Now, if we see that sign and it's quite prominent and it's there, that pretty much is, and you've got a good history and you've got raised inflammatory markers, good response to steroids, then clearly that is pretty diagnostic. And I probably wouldn't go for a biopsy in that situation because I've got enough evidence to showcase that this is GCA. It is operator dependent though. So if you've got someone who hasn't had that much experience, they can quite quickly miss something. But the good thing about ultrasound is they can move up and down in the artery, which is slightly different for a biopsy. So they can have a really good look. It can still be normal, even though you've got giant cell arteritis. So that can catch you out, and you can have other forms of vasculitides that can be picked up as well. Next slide, please. So here's a picture of the halo. So you can see on the left-hand side, you've got the blue dot in the middle, which is the Doppler. And then you can see the kind of hypoechoic area, which is the black area around, that's the halo sign. And if you look at that in kind of longitudinal, you can see that the kind of black line above and below, the kind of red line in the middle, again, is showing you the thickness of the arterial wall, which is kind of indicative of giant cell arteritis in the right context. So we want to get this scan as quickly as possible, because the more steroid that they're on for a longer period, these features will diminish over time. So we want to get that as quickly as possible. Now in Warwick, usually I can get the scan either same day or next day, but not always. So it's just something to be mindful of. But the quicker you get the scan, the quicker you can see the features before the steroids kick in and diminish everything. Next slide, please. In certain cases, so for example, the case where the temporal artery ultrasound scan is normal, or you've got someone who isn't responding as well and you're not quite sure what's going on, you may proceed to an arterial biopsy. Now, this is the gold standard, because like in anything, histology is always kind of the best way to diagnose things, but also it's obviously invasive. We don't do as many because of the role of ultrasound, which is great, but when we do need them, we need them. Timing is really, really key here, because although the guidance says up to 6 weeks, I think it says, you can do a biopsy. You can imagine if you've been on 6 weeks of steroids, that all the signs are probably going to go and you're going to get a negative biopsy potentially. So the quicker you get the biopsy, the quicker you're going to see signs. And that's why when you see someone, you want to refer them straight away. You want to get them started on steroids, and I want to see them straight away, so then I can decide if they need a biopsy or not, or an ultrasound scan. Because the quicker you can get this done, ideally within a 2-week period, the more likely you can find out if it definitely is giant cell arteritis, rather than assume, because you potentially could subject these patients to up to 2 years worth of steroids. So if you're not sure and you haven't got the evidence, would you want to take steroids for 2 years when you're not quite clear whether it is or isn't? So it's really important. There are some reasons for false negative results as well. So sampling error just means you might not actually take artery, you might take soft tissue, and you put it under the microscope and you haven't actually got a vessel. Skip lesions refer to the fact if you've got a 10-centimeter artery, for example, doesn't mean the whole 10 centimeters is inflamed. It could be little areas. So maybe between 1 and 4 centimeters, you've got inflammation, but between 4 and 8, you've got nothing. And then 8 to 10, you've got something. And if you're taking a biopsy at 6 centimeters, then it's going to appear normal. So there's always that risk that you might find a normal part, but actually you're dealing with skip lesions. And that's the other reason why they advise to take a good sample. So at least 1 centimeter of artery to put under the microscope. So again, it comes down to operator dependence as well. And don't forget, you can have age-related changes. So that's just a little bit of a kind of whistle stop about temporal artery biopsy. So next slide, please. And this is just a diagram to showcase what you see under the microscope. So you can see the giant cells, you get infiltration of the lymphocytes because of inflammation. And you can see how the kind of thickness of the wall is considerably kind of gone in, because the lumen is so small and so tight. And that's a really good example of inflammation of the arterial wall. Next slide, please. So from a secondary care perspective, next slide, please. What I do then is decide okay, they've got GCA, for example, they've got no visual disturbance, so I'm dealing with them at the moment as a rheumatologist. They usually come to me on 40 milligrams of prednisolone, so then we go down the treatment cascade of reducing that. So often they'll be on 40 or 60 for 4 weeks, and then we reduce it every 2 weeks by 10 milligrams, and then reduce it slower up to nearly 4 weeks by 2.5, and then by 1 milligram every 8 weeks. And so you can see that quite easily you could be on steroids for some time, despite the fact that you're reducing them, you're still on steroids. And so you want to monitor their inflammatory markers. You want to make sure you've done a chest x-ray to assess their aortic arch. You want to make sure you're assessing for relapses or any disabilities or complications as a result of the condition. And you may even need to consider a DEXA scan as well. So, you know, and glucose, because obviously with the steroids. So like with any form of steroid therapy, you're looking out for complications and issues, but also making sure that their disease remains in remission. So next slide, please. Important. So this could happen in primary care. They could come to you, they're on their steroids, they're quite happily bumbling away, and then they come in and they say, oh, I've got a headache again, and it feels like it was before. So in that situation, you want to kind of, again, take the history and decide, have they got any significant complications from their relapse, or is it just the headache, potentially, if they've got a headache, or is it quite mild? And again, you know, liaise with us if you're not sure, because the last thing you want to do is assume it's one thing and treat it one way, and actually it's something else. So if they've got just a headache and they say, actually, I feel okay, but it's a bit of a headache, you may just advise them to go to their previous higher dose of prednisolone. If they've developed jaw claudication, then I would say probably go back to 60 milligrams and let us know. And if they've definitely got ocular involvement, then back to 60 and back to the ophthalmologist, because they might need to have another look and see what's going on there, or they might need some IV methylpred. So this situation can definitely arise in your practice, and then you want to, you know, discuss with the patient what to do. And if you're not sure, then get in touch with whoever's looking after them, whether it's the ophthalmologist or the rheumatologist. Next slide, please. And so some situations we get resistant GCA, or we have someone who is unable to reduce their steroids, or they continue to have relapses. And in that situation, this is definitely a secondary care specialist approach. We would think about steroid sparing agents. So our first line would be something like methotrexate or leflunomide. And then now we've got licenses for tocilizumab, which is a biologic. It's an IL-6 biologic, which can help. And we've got a couple of patients on that. And then cyclophosphamide if it's considerably significant and severe. But again, that would all be done in secondary care under supervision. So next slide, please. So just a quick roundup on the complications, because this is clearly very important. So next slide, please. It's usually self-limiting. Like I said to you, you could be on steroids for up to 2 years, but you're, you know, hopefully if you're going down the kind of usual pathway, you reduce, you come off it, and usually it stays quiet. There are occasions it can come back, but equally there are times where people remain in remission and it never comes back. So, and about 20% can have some form of partial or complete visual loss as well. But the important things to maintain are just your cardiovascular risk and the aortic dilatation or rupture. So if you've got any signs or symptoms of cardiac presentations and you've got GCA, then you don't want to go, oh, it's just a bit of non-cardiac chest pain, don't worry. You want to be thinking laterally and thinking, oh, is it affecting the aorta now? Because obviously that could be very serious. So next slide, please. So just we're nearly finished now. So where are we for time? Good. So yeah, it's that's just a run through of giant cell arteritis from a patient perspective through primary care, when to refer, what to refer, how to refer, and then a little bit about what we do on our side and how you can kind of intertwine with that when they're on kind of long-term treatment. It usually, like I said at the beginning, it usually occurs more in women. It increases with age, increases with attitude as well. This is why we see a lot of it here. Next slide, please. I think it's the same slide. I might have some duplicates. So that's it. Yeah. So next slide, please. So if we go full circle back to the patient, so he obviously had giant cell arteritis. He had some raised inflammatory markers. He was started on 60 milligrams and referred to ophthalmology because he had the blurry vision. And then he was seen within 24 hours. They found there was no ocular GCA. So we reduced the steroids back down to 40, came to us. I arranged an ultrasound of the temporal artery. There was a halo sign. And then we continued treatment. So that's just, this would be a very straightforward case. Trust me, they are not always straightforward. And if you're not sure, pick up the phone or refer in and ask us, rather than just treat or not be sure. or obviously in your cases you can speak to your GPs as well and ask their advice, but that would be kind of a very classic classic presentation. So next slide please. So take home messages, next slide please. So remember, if anything, it's a medical emergency. Please make sure you start treatment as soon as they've had their bloods. Try and get their bloods before they take their first prednisolone. That can be really useful information. Liaise with us really quickly if you need to. Be mindful that all sorts can present like GCA, and make sure you don't forget about the systemic features and other complications that can arise, particularly those without a headache, because that can often get missed as well. And so next slide, please. I think that's it. Yeah, so that's everything for today. Thank you so much for listening. Thank you for your patience, and thank you for me not putting my camera on, but I'm more than happy to take any questions or clarify any matters. And I'm happy to come back to that point about A&E as well.
Someone is typing a question to you.
Mm-hmm.
So whilst you're having a glass of water and we're waiting for the question, thank you very much. You did it in brilliant time. 13:26. Oh, it wasn't a question. It was just a comment saying thank you for the presentation.
Oh, thank you very much. I'll just go back to that A&E question then, just briefly. So in that situation, I would not refer to A&E without doing anything. And I'm not, apologies if I've misunderstood, but I would expect you to do some bloods, or at least give them a form. And I would expect you to start some steroids. I wouldn't just send them to A&E. Firstly, they'll be sat in A&E forever, with nothing. They probably could have got their bloods quicker elsewhere rather than waiting for A&E. And A&E often don't do anything. They just refer back to AMU or refer to us. And we don't have a 24-hour service, so if it's the middle of the night, it doesn't really work. So I wouldn't go to A&E. I would look at your local pathways. If you're not sure, you can just pick up the phone. There's my details, so you can pick up the phone. This from a private perspective, though, to be fair. You can pick up the phone and say, can you see this patient urgently? I'm not sure what to do. That's not a problem. But yes, if you do that, that actually gets our backs up, because nothing's been done and they've just been literally signposted somewhere else, as if, and the GPs are more than capable of managing the first part of it. It's better to get the blood and start the treatment and then realize actually it's not GCA. That's okay, but it won't be okay if they have got it. And it, particularly if you send them to A&E, they've got ocular features or visual problems, like I said, within 48 hours things can go very bad. Equally, the other thing I didn't really talk very much about is putting them on steroids and then not getting them referred in, or having a delay in getting seen, is also just as bad for several reasons. One, the longer they're on steroids and we can't get investigations, the less likely we can determine if they have got GCA for sure, particularly if they're not a classic presentation. And then we're kind of working in no man's land, because they've been on steroids for so long, we don't know what to do, and we have to just wean them off and what I call adopt a watch and wait and see what happens. So we've subjected them to steroids long term without really knowing what's going on. So there's that issue. And secondly, I forgot my second point now completely. Yes, it affects the investigation. So it affects the investigations, and then you can get complications from the steroids. I remember one person getting full-blown diabetes and having complications of diabetes purely iatrogenic, because they were just left on high-dose steroids for weeks and weeks and weeks and weeks and weeks, and they hadn't been seen. So as a caveat for you, I would ask the patient, say, look, if you've not heard anything from secondary care or had a referral or been seen within, say, 2 weeks, can you please contact me and let me know, just to give them a safety net to come back to you, so they're not left on these high-dose steroids without anyone seeing them. And patients are really good. They just keep taking them because they think that's the right thing to do. They don't question anything. Many don't anyway. Maybe the new generation do, but not so much the older generation, which is the people that you're often dealing with. So yeah, do give them that safety net as well, and check in with them. Have you been seen? Have you know what happened? And you'll get the letters, but it might be a bit of a delay. So I'm trusting that helps with that question comment from whoever rose it about A&E.
And it's still 13:29.
Oh,
that's perfect
too good and not well.
If there aren't any more questions, just like to say thank you again, Sonia, and thank you to those of you who have joined. Vicky has added in, and thank you, Vicky, for doing the slides. Vicky has added in a link to the feedback form, and it would be hugely appreciated if you wouldn't mind taking a couple of minutes to do that. and in the next few days or early next week, I can send out a copy of the presentation and your CPD certificate. So thank you very much, and have a good rest of the day.